Hello, everybody. Welcome to this webinar entitled Keeping Up with Change, the Delta Variant and Pulmonary Embolism Deep Vein Thrombosis. This educational activity is sponsored by the Pulmonary Embolism Response Team Consortium, and it is kindly supported by Angiodynamics, Boston Scientific, Inouye, Janssen, Johnson & Johnson, and Penumbra. My name is David Jiménez. I'm a respiratory physician at Ramón y Cajal Hospital, Madrid, Spain. And I would like to introduce my distinguished faculty. Today, Dr. Julie Jaffray. She's director of the thrombosis program and a pediatric hematology oncology specialist at Children's Hospital in Los Angeles, California. Dr. Hooman, he's an associate professor of medicine and director of pulmonary vascular disease, Mount Sinai National Jewish Health Respiratory Institute in New York. Dr. Edward Ryan, he's director of global infectious diseases at Mass General Hospital and professor at Harvard University in Boston, Massachusetts. And last but not least, my colleague and friend, Dr. Andrew Sharp, who is a consultant cardiologist at the University Hospital of Wales in Cardiff, United Kingdom. Thank you very much for joining us today. And just some housekeeping. Please mute your microphones, and you will have the opportunity to ask as many questions as you wish during the presentations. And the panel will try to address all those questions in the last 20 minutes of this webinar. I would like to remember that you can participate in this very interesting initiative of the PERT Consortium, which is the COVID-19 Pulmonary Embolism Registry. I am convinced that this registry will provide us with very important information for the management of patients with COVID-19 and venous thromboembolic events. And of course, feel free to register in the 7th Annual Pulmonary Embolism Symposium, sponsored by the PERT Consortium, that will take place virtually on October 14th to 16th. So without any further delay, I would like to introduce Ed Ryan. He will provide us with an overview of COVID-19 and variants. Thank you very much, Ed.
I was asked, so I am not a thrombosis guru, but I am an infectious disease person. And I was asked to spend a few minutes at the beginning just to say, where are we in the COVID pandemic and what might be coming down the road in the future. So, these thoughts are basically just my own personal thoughts, but hopefully they'll give a context. So here in the United States, and I'll show you global in a second, we are on the downtrend of the 4th wave, which was largely Delta. And if you see the numbers in the upper right-hand side, we have reasonable amount of vaccine coverage, but certainly not 100%, and we're never going to get to 100%. Our trend is coming down. Globally, COVID is also coming down for the most recent wave. Remember, we didn't have great testing earlier on, and that large blip that you see there for the last wave is largely Delta. Recognize, though, that about 1/3 of all cases reported globally are from the United States alone. And so there's a real reporting bias. But having said that, globally, it does look like cases are downtrending in many areas of the world. Now, you know this already, but vaccines work. I'm not here to preach to the choir, but I will show you here, say in Massachusetts, where I practice, we have about 90% of the population over the age of 18 has had at least one dose of vaccine, and 80% are fully immunized. So you can use us as an example of if you have a well-vaccinated population. And what you see is that with Delta, cases went up, hospitalizations went up, although to a much lower level than what we saw with the previous waves, and deaths just tweaked up a little. And if you look at the percentage changes here, for each of these categories, we go down almost by another log. I should say that this, and we'll get to this in a second, and the pandemic has shifted. Almost all these cases that you see in red and in purple are younger individuals, and they're all unvaccinated. So other things do work. We won't spend time on this today because I wanted to focus more on the global aspects. But in the last 24 months or so, we've made excellent progress in a number of areas. We now have a number of effective drugs and clear indications for when they help or don't help, remdesivir, Decadron, and tocilizumab. We also have monoclonal antibodies that have also been shown most recently to prevent disease, both in contacts and in people who are exposed. But these are all very expensive and they have limited utility, exceptionally for the first ones. And without a doubt, we get the most bang for the buck at preventing all these things with using vaccines. Will Delta go away? And the quick answer is no, not anytime soon, but vaccinated communities have probably been through the worst since Delta was first detected in India. We will plateau, for instance, if I use the United States as an example, we will plateau at some value after our peak, and then the tide will rise over the winter and the tide will fall by the spring. And I want you to remember the way I view the pandemic now is a tide. It's going to go up, it's going to go down. It's never going to go totally away. Stop thinking that the goal is to prevent infections. That is unrealistic. COVID-0 is gone. It's not going to be any reality. And the goal is and needs to stay focused on preventing death and severe disease. So once again, the tide will go up, the tide will go down. Just make sure that anybody who wants a life vest has a life vest. And the best life vest is the vaccine. And you have to remember that it's not to undermine social distancing and masks, but those really are secondary aspects now. It should be vaccine, vaccine, vaccine. Now, where are we going to plateau? It's hard to know. If you look at the United Kingdom, they had their Delta spike and they're plateauing pretty high. If you look at Germany, they're still on the downslope, but it sort of looks like they're going to plateau also at a reasonable level. And what's interesting, if you look at India, and remember Delta first was detected in India, they really have plummeted down. Now, whether this is a detection issue or whether this is because such a low percentage of the population was immunized when Delta flew through, and whether this represents that a good chunk of the population has now been exposed to Delta, and therefore that plateau doesn't exist, is unclear. But I think we can predict that in all the places that have reasonable vaccine rates, that you're going to see a plateau that'll rise over the winter and then fall again. We just don't know that height. Now, Delta, the R naught, remember the transmissibility of it is about twice of Alpha. That was the B117, which was about twice the original Wuhan wild type. And so the Delta R naught is about 2.5 to 4.5. So that means that for everybody who gets Delta, all else being equal, they'll infect about 2 to 5 people and transmit it onto them. Now, vaccination cuts that risk in half. So in reality, our R naught is back to where we sort of were a year ago, because it's doubled, but then we've cut it in half with vaccine. So at the end of the day, the transmissibility is where we really were about a year ago. And it means that Delta will fly through even vaccinated communities. But death and destruction will largely be the unvaccinated, but the intense pressure on even the vaccinated people will lead to some deaths because it's all percentages among the vaccinated. And Israel saw this when they had their most recent Delta wave in a relatively well-immunized population. They also saw an increase in deaths. And they went on and as you know, they introduced the booster vaccine, and that booster vaccine in individuals who were boosted, it lowered the death rate among the boosted people compared to the non-booster by about 90%. So that's the context where the big debates that have been raising about booster recs. And as people are aware, so it's just over the last week, booster vaccine, or booster immunization has been approved for the Pfizer BioNTech vaccine in the United States. According to the ACIP talks last week, CDC estimates that for every 1 million dosages of booster, that will prevent about 2,000 hospitalizations. They didn't go to the death thing, but at least in our hospital, we had about a 10% death rate with the first waves. We're more at about a 5 to 6% death rate. So I'm going to estimate with the current wave. So I'm going to assume that this will be for every million dosages, you'll be preventing about 100 to 200 deaths. The Moderna vaccine actually provides a little better longer-term field efficacy than the Pfizer, it appears to be, and there's slightly different immune responses, a little more IgA, some functional antibody responses. We don't really understand the differences there, but the point is moot at one level, because the Moderna immune responses also follow with time, and Moderna has applied for booster vaccines as well. And the same J&J is also requesting booster vaccines as well. So I suspect at a public health level, you're going to see all of these eventually get approved in the United States. Now, one of the reasons why there's been so much concern and debate, and there's a couple, there's ethical issues, logistic issues, et cetera, is that should everybody get a booster, but only certain high-risk individuals? And the logic there is that for the adverse events from the vaccines, especially in younger individuals, example, myocarditis, when do we start to change the risk-benefit calculus for those younger individuals versus, say, an 85-year-old with a lot of comorbid conditions? And remember, we will never be COVID zero. So the goal is to prevent severe disease to death. We don't have time to go into these decisions, but recognize there's not only clinical aspects, but public health aspects, perception aspects, and political aspects. So right now, anybody who's immunocompromised and certain high-risk groups, I'll tell you how this probably will march out. It'll be if it's 6 months from your vaccine. At the beginning, that's largely high-risk individuals and healthcare workers, and eventually other groups will be pulled under that umbrella, and it'll be basically open for anybody who wants to get the vaccines, and the other Moderna and Janssen vaccines will also come on. I would actually say we shouldn't think of these as boosters. I would actually view it as this is long-term immunological consolidation, and we do that with other vaccines. For instance, hepatitis B, we give it 0, 1, and 6 months, HPV, 0, 1, and 6 months, and the new rabies one in the United States with the upfront ones and then a late one to consolidate long-term immunity. So we do this with many vaccines. Right now, only Pfizer, and don't miss or match. How about kids? In works for 5 to 11, Pfizer just put in their request to the FDA today, about an hour or two ago, that they're pursuing approval for use in 5 to 11-year-olds. Now, certainly some very high-risk individuals, immunocompromised kids, organ transplants, severe cardiopulmonary, definitely should be vaccinated. Some kids get MIS-C, unclear if vaccination is going to prevent that or not. We just don't know. And then vaccinating kids will also lessen transmission pool to the general population. But remember, most kids do fine. So there's going to probably be some real battles here about whether vaccines should proceed with younger kids or not. For the 12 to 15-year-olds, where we've had the vaccines now approved for quite a while, only 40% of parents have vaccinated their kids, or 40% of kids have been vaccinated. I suspect when it gets lowered, we're only going to be looking at about 20 to 25% of those kids will actually get vaccinated. Globally, the horse is out of the barn. The majority of the world has seen or will see the virus before any additional vaccine rollout over the next 12 to 18 months. And that's largely because Delta is so highly infectious. And those individuals either lived and are immune, or they've died in areas of the world that bore a large burden, or they've received a vaccine in a low transmission area like China, or they've received a vaccine in a high transmission area like Europe or the United States. These low transmission bubble zones, especially if they have vaccines of lower efficacy, are going to have a real problem reintegrating back into the world. Because, how do you open up your borders, et cetera? We don't have time to go into that one today. What are we seeing in hospitals? The burden mirrors the percent unvaccinated. In low vaccine areas, hospitals are being overwhelmed. In high vaccine areas, admissions are basically all unvaccinated. And it's younger and healthier, but that's largely reflecting who are not vaccinated. That'll have implications for the clinical sequelae, including thrombosis, et cetera. We'll hear about that. The case fatality rate, at least at our hospital, seems to be lower than in the first waves, but that largely might be a population issue. So what will the future hold in the last slide or two? In some ways, Delta has been fortuitous. I'm in the philosophy things could always be worse. For several, it's a variant that was selected for transmissibility, not for immune evasion. It is also not appreciably more deadly. And it has beaten every other variant to date in any transmission battle, including a number of variants that would have caused our vaccines many more problems. It is effectively auto-boosting many, and it's preventing spread of immune escape mutants, but that balance will probably change shortly. So here's the finals. As we enter our third year, believe it or not, since the pandemic first started spreading among humans in the fall of 2019, the official global count is about 200 million infected and about 5 million deaths. The real number is 2 to 3 billion have been infected, 3.5 billion have been officially vaccinated. So 65 to 85% of the world has either seen the virus or the vaccine, and global deaths are really 10 to 25 million. There's about 40 vaccines that are out there globally. Many of those vaccines are not particularly great, and even the great ones wane over time. So SARS-CoV-2, as we are chatting here today, is replicating in tens of millions of people, each with trillions and trillions and trillions of virions. So the summary is we have created a perfect environment for selecting immune escape variants. The good news is, as long as we do genomic and immunological surveillance and we have rapid pivot platforms like mRNA vaccines, we'll be able to pivot. So it's either going to be somewhere between these two extremes. Best case over the next year or so, either Delta will cool, the global burden will fall, no immune escape variants will sweep the globe, it won't get any more virulent, and this one will join the other 7 coronaviruses that infect humans, endemic among kids, usually just causing colds. And once we cool the globe, the likelihood of an immune escape variant will become much likely. Worst case scenario, an immune escape variant will develop with high transmission potential, and also worst case scenario, high case fatality rates. Once again, to prevent that end of the spectrum, we need to maintain our genomic and immunological surveillance and make sure we have rapid vaccine development and response. And we're into year 3, and I'll stop there.
Thank you for the fantastic presentation. I will hand over to Andrew. He will present a clinical case with some controversies in the diagnosis and treatment of venous thromboembolism.
Thanks, David. Tough to follow such a great talk. Thanks very much, Dr. Ryan. So I'm going to talk about a case of a patient who has the Delta variant. One of the differences we've seen is younger patients. I think that's the really striking thing about this wave versus the first wave. So this is a 33-year-old male. He's unvaccinated. He was offered but hasn't taken it up. He's got no past medical history of note. He presents with 7 days of fever, cough, and breathlessness with a temperature of 38.8 and a marked tachycardia with a low normal blood pressure and profound hypoxia, which corrected to 88% on the maximum rebreathe we could do in the emergency department. His respiratory rate was 28 and he was unwell. This is his initial chest x-ray. I think we've all seen this. It brings back nightmares. His lab work, he's got a very high CRP, a very high white cell count driven by a neutrophilia, and renal function shows mild impairment, but thankfully not too bad. So what is the diagnosis? Well, his first COVID PCR test was negative, which surprised everybody involved with his care. He was immediately isolated, and we all assumed that this was going to be the Delta variant and this was going to be a positive PCR test. He went on to have a CTPA, apologies for the slightly shaky image. But as you can see, he's got pretty florid pneumonia. And as you'll see when you get down to the ventricle, he's got a significantly dilated right ventricle. And the eagle-eyed amongst you will have spotted some pulmonary embolism in there on the right lung in particular. This is the coronal shot. Again, really florid pneumonia. I think we saw this in the first wave. We saw this in the Alpha variant. But what's different is this is a young kid who's got no apparent reason for having this. And hopefully you just saw flash through there some pulmonary embolism in the coronal stack. I'll let that run once more. Keep your eye on the truncus and the interlobar artery on the right. He's got also a segmental and subsegmental thrombus. Hopefully you saw it come through there. Significant right ventricular strain, maybe disproportionate if this was a non-pneumonic lung. To see just one-sided, mostly one-sided clot. There are a few subsegmentals on the left, but again, we've seen this with COVID where you have profound COVID lung and pulmonary embolism and you see RV strain, and it's very difficult to work out what's due to the PE, what's due to the lung, and what's due to something else. So diagnosis and treatment. So he's got one COVID PCR test, so what to do next? So the differential diagnosis remained COVID pneumonia. We just assumed it was a false negative. We've identified a pulmonary embolism in there and wondered about secondary bacterial pneumonia, but still COVID was at the top. He was given broad spectrum IV antibiotics and put on Clexane, given some dexamethasone, and initially was tried with CPAP, but rapidly fatigued and required intubation. So progress, very high FiO2 requirements on a ventilator. His second COVID PCR test was negative. So again, we're all pretty shocked by this. But one of our senior ITU doctors just said, relax, it's COVID. And we all thought he was being a bit Jedi Master, but in fact, he was. He insisted on a bronchoalveolar lavage, and COVID came out positive, strongly positive on the sample. Perhaps we can talk at the end about why he may have had 2 negative PCR tests, but this is COVID lung. So he was offered to me for consideration of catheter treatment after about 24 hours on a ventilator. I think I was going to ask the panel now, but we'll save it for the end. So have a think about your responses, and we've got 20 minutes to discuss all the facets of this webinar at the end. So he was treated medically initially. Tocilizumab was added, monoclonal antibody to IL-6 receptor that the recovery trial has demonstrated a 15% reduction in serious adverse events. And he went back on day 6 for a repeat CTCA, having had dexamethasone and tocilizumab. And you can see here, it's a little bit better actually. And the eagle-eyed amongst you will have seen that the right ventricle is no longer severely dilated, despite a similar clot burden on the CTPA. So he's had 6 days of Clexane, 6 days of dexamethasone, and he's still got this clot, which has been reported by a chest radiologist as being unchanged, and yet the RV strain has gone. So he has an improving pneumonia that's almost certainly entirely COVID. He's got little change in thrombus burden of a pulmonary embolism to the right lung. He's still intubated and requiring very high oxygen requirements, despite improving lung fields on a repeat CTPA, and he's still on therapeutic Clexane, which is being titrated to anti-10A levels rather than using IV heparin. So what role is the pulmonary embolism playing in his ongoing oxygenation requirements? Should we have considered interventional therapies at the beginning or lysis? Should we consider interventional therapies or lysis now? And perhaps we can discuss all this at the end of the webinar, having heard from our expert colleagues more about COVID and pulmonary embolism. Thanks, David. I'll hand back to you.
Is about the very controversial issue of inpatient thromboprophylaxis. So the floor is yours, Dr. Poor.
Great, thank you for inviting me. Yeah, so my name is Hooman from Mount Sinai in New York City. And yes, as Dr. Jiménez mentioned, thromboprophylaxis in COVID-19 was very controversial and remains extremely controversial now. And I think that the presentation by Dr. Sharp highlights a lot of the issues that we deal with. So early in the pandemic, it became exceedingly clear that the rates of pulmonary thrombosis and thromboembolism was notably high in patients with COVID-19, and that the pathophysiology seemed to include kind of two different pathways: the classic thromboembolism, where you develop a DVT in the milieu of a hypercoagulable state that then embolizes to your lungs and develop PE. But also this concept of immunothrombosis, where because of the inflammation in the lungs, you would develop in situ microvascular thrombosis and thus pulmonary thrombosis. And so a lot of us during this first wave of the pandemic noted, high rates of DVT and PE and high rates of clotting of pretty much everything. Specifically catheters and so on. An autopsy series had shown many instances of micro kind of in situ clots as seen here. Kind of putting numbers to this, this was a meta-analysis by Dr. Jiménez looking at the incidence of VTE, and the pool incidence was about 17%. But this was highly variable depending upon the assessment of this study. Specifically, were these patients in the ICU versus not in the ICU in the wards, because the rates were clearly much higher in patients who required ICU level care. Also, in terms of how the events were counted, were those who had symptomatic versus asymptomatic PE, and very importantly, testing strategies. So were patients undergoing testing for PE because of clinical suspicion on top of the COVID pneumonia that they may have, or were they undergoing systematic screening, which would result in higher rates. And then many studies had a varying degree of thromboprophylaxis. Some studies had patients on no thromboprophylaxis, others on standard prophylactic doses, others with intermediate, and some even on therapeutic. One study that really caught my eye during all of this was a systematic screening study in patients who went to the ICU. It was about 70-something patients. And upon entering the ICU, they underwent a CT angiogram of essentially the whole body, and 47% had PE. And importantly, only 7% of them were clinically suspected of having PE. And I think this case that was just highlighted, a patient with bilateral infiltrates and hypoxemia, one doesn't necessarily think they have a PE. It can be explained simply by COVID, but clearly these clots are occurring. Another aspect early in this disease that was noted by Gattinoni was this weird concept where we thought that this was a classical ARDS scenario, where with ARDS you have inflammation of the lungs, pulmonary edema, stiff lungs, decreased compliance, and also impairment in gas exchange. But particularly early in the disease, it was noted that there may be some kind of disconnect where the lungs were not so stiff, yet the hypoxemia and shunt fraction was exceedingly high. And the concern was, well, if there are all these clots going on, all these high rates of PE, these microthromboses, could this be the cause in terms of some of these detriments in gas exchange? And so as a result, early in the pandemic, many people just anticoagulated. They therapeutically anticoagulated their patients, especially those who are critically ill, both for these small clots and also the high rates of VTE. And when you look at retrospective studies, this is a study actually out of Mount Sinai, about 4,000 patients admitted with COVID-19, therapeutic anticoagulation, there was a trend towards a survival benefit. You can see a p-value of 0.08, and here it crosses barely over 1. And this was at an institution that was, very heavily using therapeutic anticoagulation. But it's important to note that you must be careful of the conclusions that you draw from retrospective observational studies. And ultimately, it's with randomized controlled trials that it's important to really delve into the effect of anticoagulation on the outcomes that we care about. And so very recently, we've had a slew of these studies that have come out that have shed a little bit more light and probably added to more confusion as to what we're actually supposed to do and what's going on. The first was a study out of Iran and published in the JAMA, looking at the use of intermediate dose prophylactic anticoagulation in patients admitted to the ICU. So 600 patients admitted to the intensive care unit, and they were randomized to this intermediate dose anticoagulation, which was enoxaparin 1 milligram per kilogram daily versus a standard dose prophylactic of enoxaparin 40 milligrams daily. And again, early in the pandemic, all kinds of doses were being used for prophylaxis, ranging from standard prophylaxis to new doses like these intermediate doses. The primary outcome was a composite of venous or arterial thrombosis, treatment with ECMO, or mortality within 30 days, and there was no difference in the primary outcome. There was, however, a higher bleeding rate in the intermediate dose group of about 2.5% compared to 1.4 in the standard dose. And so the question here was this not effective because the dose wasn't high enough? Which leads us to the trial, the REMAP-CAP, Active4A, and the ATTACK platform. This was a very large trial, about 1,000 patients with severe COVID-19 who were critically ill. And it's important to note that the definition of critically ill meant requiring any of these supportive measures: high flow nasal cannula, non-invasive ventilation, mechanical ventilation, ECMO, vasopressors, and or inotropes. Many of our patients during the height of this pandemic were on high flow nasal cannula in the wards. However, they would still be considered critically ill. They were randomized to therapeutic anticoagulation with heparin versus usual care, pharmacologic thromboprophylaxis. And the primary endpoint was organ support-free days. This trial was actually stopped early because of futility. And notably, there was actually a 95% probability of inferiority with therapeutic anticoagulation, meaning that this actually was very highly likely to cause harm in this patient population. The bleeding rates were a little bit elevated, 3.8% versus 2.3% major bleeding, not massively elevated. And so it's not entirely clear as to what the mechanism of harm is with respect to anticoagulation, but definitely no benefit. And so either these patients are too far gone with their kind of thromboses, or the thrombosis is more kind of a sideshow, and that the driver of disease is something else. Additionally, it may be that some of the kind of microhemorrhages that they have in their lungs as a result of the inflammation and so on may be exacerbated, but ultimately therapeutic anticoagulation was not beneficial and potentially harmful. So what about those who are not as ill? The same group also looked at patients who were not critically ill with COVID-19. Again, about 2,000 patients hospitalized with COVID-19, but not having any of these ICU level supports. And they were randomized also to therapeutic anticoagulation with heparin versus the usual care, pharmacologic thromboprophylaxis. It turned out that their study was actually positive, that therapeutic anticoagulation increased the probability of survival until discharge with a reduced need for ICU level organ support at 21 days. So basically, 80% of those who received therapeutic anticoagulation were hospitalized and discharged without needing ICU level care, compared to 76% in the usual care. So it's a small percentage difference in an outcome that that's important, but still not, you know, a big splash. This did come with the cost of a slight increase in bleeding rate, 1.9% versus 0.9 in the usual care. That again was with heparin. The question then is, what about other anticoagulants? So this was a trial of 615 patients hospitalized with COVID-19 and elevated D-dimer. And they were randomized essentially to therapeutic anticoagulation with rivaroxaban. 90% of them got rivaroxaban, 10% got heparin. Those were the critically ill ones, versus usual care pharmacologic thromboprophylaxis. Their primary outcome was this hierarchical analysis of time to death, duration of hospitalization, or duration of supplemental oxygen to day 30. And there was no difference in primary outcome. And the bleeding rates, this is all bleeding, not just major bleeding, was higher in the therapeutic anticoagulation group, 8% versus 2% in usual care. Again, the not critically ill group, this is a group that got the rivaroxaban, no benefit seen, implying perhaps that there may be something specific about heparin relative to the other anticoagulants like rivaroxaban. So in summary, pulmonary thrombosis and thromboembolism are common in patients with COVID-19. Prophylactic anticoagulation with therapeutic or intermediate doses does not improve outcomes in critically ill patients with COVID-19. And therapeutic anticoagulation with heparin may improve outcomes in those who are not critically ill, patients who are hospitalized with COVID-19. Thank you.
So thank you very much for the presentation. I think that I'm next, and my talk will deal with thromboprophylaxis in outpatients and after hospital admission for COVID-19. This is my disclosure slide. I have no relevant conflict of interest for this particular presentation. And before the pandemic, clinical practice guidelines did not routinely recommend outpatient pharmacological thromboprophylaxis for acutely ill medical patients who did not require hospital admission. And one potential exception might be high-risk outpatients with active cancer. You know the results of the AVERT and Cassini trials? These trials demonstrated a clinical benefit for apixaban and rivaroxaban, respectively, in outpatients with active cancer and at high risk for venous thromboembolic events, meaning a Corona score of 2 points or higher. For this reason, clinical practice guidelines did not recommend pharmacological thromboprophylaxis for outpatients with COVID-19. For instance, the NIH recommendations state that for non-hospitalized patients with COVID-19, anticoagulants and antiplatelet therapy should not be initiated for the prevention of venous thromboembolism or arterial thrombosis. However, we have some ongoing randomized controlled trials trying to address this particular issue. The only one that have been published so far is the SOLACE trial. The SOLACE trial randomized 243 outpatients with a diagnosis of COVID-19 who were randomized to sulodexide or to placebo. The primary efficacy outcome was need for hospitalization. And this trial was positive, meaning that the proportion of patients who required hospitalization in the intervention arm was significantly lower, 18%, compared to the proportion of patients in the placebo arm, 29%. In addition, fewer patients require supplemental oxygen in the active arm as compared to the placebo arm. However, this was a small sample size trial, and there was a subjective primary efficacy outcome, and there was lack of blinded adjudication. So for this reason, I think that we have to wait to confirmatory multicenter randomized controlled trials before we can recommend routine thromboprophylaxis for outpatients with COVID-19. And what about post-discharge extended thromboprophylaxis? This means pharmacological thromboprophylaxis that is indicated after hospital discharge. And these are the results of 3 landmark randomized controlled trials for non-COVID-19 patients. The Abbott trial with apixaban, the Magellan trial with rivaroxaban, and the Apex trial with betrixaban. And to make the story short, these trials suggest no clinical benefit for extended post-discharge thromboprophylaxis for non-COVID acutely ill medical patients. And this is the reason why clinical practice guidelines did not routinely recommend extended thromboprophylaxis for these patients. For COVID-19 patients, clinical practice guidelines suggested against extended thromboprophylaxis in this population. For instance, this is the recommendation by the CHEST guidelines, co-chaired by Dr. Moore. In patients with COVID-19, we recommend inpatient thromboprophylaxis only over inpatient plus extended thromboprophylaxis after hospital discharge. Again, there are some ongoing randomized controlled trials in this area. None of these trials has been published so far, but we have the results of the Michel trial that was presented early this year in the European Society of Cardiology annual meeting. The investigators of Michel trial randomized 318 adult patients hospitalized for SARS-CoV-2 infection to extended thromboprophylaxis with rivaroxaban 10 milligrams once daily or to standard management. Of note, these patients who were randomized in this trial had a high risk for venous thromboembolic events assessed by the modified improved BTE score, which had to be more than 4 or more, or 2 to 3 plus a positive D-dimer testing, higher than 500 nanograms per milliliter during a hospital admission. The primary efficacy outcome for this trial was a composite of fatal or non-fatal venous thromboembolism or symptomatic arterial thromboembolic events. And you can see that rivaroxaban significantly reduced by 67% the risk of the primary composite outcome, with a number needed to treat of 16 patients to avoid one event. And none of the patients experienced a major bleeding event during the first 35 days of therapy. I think again that we have to wait to have these results published in a peer-reviewed journal before making strong recommendations about extended post-discharge thromboprophylaxis in patients who require hospital admission because of COVID-19. So in conclusion, I do not routinely recommend pharmacological thromboprophylaxis for the vast majority of outpatients with COVID-19, and post-discharge extended prophylaxis might be considered in selected high-risk cases who do not have high risk of bleeding and who understand the uncertainties of evidence in the setting of COVID-19. Thank you very much. I will stop it here. So last but not least, I will hand over to Dr. Jaffray. She will provide us with the pediatric perspective of the Delta variant. Thank you.
Hi, everybody. Thank you so much for inviting me. And hopefully, if you guys are not pediatricians, you have children. And so I can give you some sort of information on what we know about how children are doing these days with the Delta variant. So as Dr. Ryan alluded, the Delta variant is basically all the COVID cases right now in the United States. And I put this up so just so you understand All the updates I'm giving you from July in children are really just the Delta variant. And it doesn't matter if you're a child or an adult, that is really what we're talking about in these last couple of months. So this is looking at our US data for COVID-19 in children. And as you can see here by this graph, we've got the cases of COVID-19 in all age groups from the beginning of the pandemic. And as you've seen by the past graphs that each of us have shown, there's the big peak that was in January, and now we had a smaller peak here in August. But what I really want you to focus on are the age groups. So the yellow lines are all the ones that represent children. And as you can see, and as we also talked about as well previously, the children are really the predominant cases because one, most of them are not vaccinated, unfortunately. Hopefully soon we will have the Pfizer approved for use in children who are 5 and older. But many of the children, at least in most of our states, we are not as great as Massachusetts here in California. Even our teenagers who can get vaccinated, a lot of them still aren't. And what I also wanted to point out was that in the end of August, you can see the highest peak, and the 0 to 4, the 5 to 11, the 12 to 15, all of these younger kids are really the predominant group of kids, people getting COVID. And I just wanted to give you the most updated 9/11 was when I put these slides together a little after that. Again, the younger population is the predominant group. Another thing that is very specific to children mostly is the multi-inflammatory system that's we are dealing with a lot in the hospital for children. And really the biggest incidence of thrombosis in children are those with MIS-C. And this graph nicely shows that you've got your COVID-19 in the black dotted in the peaks, just like we saw. And then about a month or so afterward, this is when we start seeing MIS-C coming into our hospital. And I will tell you, if you talked to me 2 weeks ago, I would say we really haven't been seeing too much MIS-C. It really dropped off. And not surprisingly, over the last week, we have been seeing more and more MIS-C here at my hospital. And luckily, we have an amazing group of doctors who have come together, because you really do need a multidisciplinary team to take care of these patients, from ID and hematology and cardiology to really care for them. What we also noticed with MIS-C, and this is data from previously, and we'll see if that changes with the Delta variant, but the big group is actually those who are about 6 to 11 years of age in terms of getting MIS-C, but it really affects all age groups, and unfortunately, even those who are under 1 year. So what's going on with hospitalizations because of the Delta variant? And again, this is our timeline over COVID, but what you can see, this is just children, this entire graph, and different age groups. So we are now seeing about 1.4 of every 100,000 children and adolescents are now hospitalized with COVID-19. And this is 5 times the weekly rate that we saw in June. So definitely going up throughout the summer and now hitting the fall. In terms of hospitalizations overall, the rate of unvaccinated adolescents is about 10 times higher than those who are vaccinated. So again, as we said before, speaking to the choir, but please, I'm trying to, as much in my practice, to promote vaccination. And I will tell you that it is shocking how many parents and adolescent teenagers are still not vaccinated that I see in clinic. The biggest thing I'm trying to tell them is that these kids are still getting sick. I think many are surprised that we have any sick children in our ICU with COVID, and hopefully that does urge them to get their child vaccinated. We are seeing right now that children who are 0 to 4 years of age having the highest hospitalization rates. So this is very different than the beginning of the pandemic. 46% of them are typically healthy children. So that's also a big change. And I think what a lot of the community doesn't realize is that these are not all children with big medical histories. These are kids that were otherwise well that are getting in the hospital. The good news is that even with the Delta variant, we're not seeing increase in disease severity and needing to be in the ICU with our children. It's the same rates as they were before, so that is something. I think, of course, we all appreciate that it is a little scary that all the schools have opened up with some masking and some not, and some having distancing and some not, yet the majority of children that are school age are unvaccinated. Just to look at pre and post Delta in terms of hospital interventions, just to go through this to let you know that, again, the good news is it hasn't gotten worse, and the need for being in the hospital has been about the same. Those who have died in the hospital, those who have needed an ICU, those who've needed vasopressor support has been fairly stable pre and during Delta. And then looking at mechanical ventilation, a little bit higher with the Delta variant, but not close to statistically significant for those that, but you can see a little bit higher. So there has not really been any published data. So all of that was from our CDC, but of course it takes a while to publish the data of what's going on with the Delta variant in children. But for those of you who aren't following pediatric data closely, I wanted to just let you know what is out there. So in terms of who were infected, about 2 to 11% of COVID-19 infections were in children before the Delta variant came up, less severe in children, which I think most of us can appreciate. Many children, unfortunately, are asymptomatic, so it's important that the schools who are doing it continue to do their monitoring of testing. From now with the Delta variant, we see about 16% of cases are children, so certainly much higher than before. In terms of VTE specifically, we are all people here that care about VTE and pulmonary embolism. Luckily, not at the same rates as what we see in adults, but certainly there. There have been a couple of big studies. One looked at 295 children. It was an international study. They had 2 children with a VTE. One of them had a PE. They did have a few children with bleeding, some of them on anticoagulation and some not. We have been certainly following in all of your footsteps on anticoagulating those children that we deem to be at high risk. Either they have normal risk factors for VTE or elevated D-dimer. There was one study that looked at their patients. This was at Montefiore, so one of the really big centers at the very beginning. They had a much higher VTE rate, up to 18% in children and 23% in their young adults. This paper came out in Blood. I will tell you, I was a part of it. It looked at our COVID-19 and MIS-C patients. I would say the great news is it had some data about thrombosis. I'd say the bummer is that we stopped collecting patients in October. So we would love an updated paper looking at thrombosis and COVID in children once we hit that big December, January wave. But we did have 823 patients, admissions for this group. We had 20 of them with VTE, and we saw the highest incidence of those with MIS-C, and especially those who were adolescents with MIS-C. We did again have some bleeding, and some of those patients were on anticoagulation. We are mostly doing prophylactic dosing in our children. This was from the same paper, again, looking at who exactly is getting thrombosis, not surprisingly, mostly the adolescents, and as I said, mostly those with MIS-C. So those are the ones I'm at least being doing a lot more anticoagulation with the MIS-C. In terms of thromboprophylaxis, at this point in the pandemic, About 30% of our patients were getting prophylaxis, mostly in the ICU. But as we've also seen in the adult data, that it isn't perfect, and many of our VTE events still occur even with anticoagulation. Most of the time we're using enoxaparin Q12 dosing in children. So what are the guidelines out there? Well, we are really following step from you. These were pediatric guidelines put out pretty early on in the pandemic. This was just a survey of hematologists. I was one of them, and ICU doctors from around the world on who should receive anticoagulation if you're a child. And we basically said, if you have a really high D-dimer, and if you have, or if you have high risk factors for VTE. So this paper came out in JTH last year. These were all the risk factors that we decided as a group put you at risk for VTE, which are very similar to many studies in children and not terribly different from the adults. We then, this came out as an algorithm earlier this year to decide who to put on anticoagulation. It's a nice paper that just has different children with leukemia, children with sickle cell disease, obese children, which we're seeing a lot, is who I'm putting on anticoagulation, and who you can send home without any anticoagulation. So for those of you who are pediatricians, I think this paper is really nice to kind of help you walk through that. So that's the end of my pediatric slides, and I'm happy to take questions with the rest of the group.
So thank you very much for the great presentation. We have some minutes for discussion. We can do quick questions and quick answers, please. And I would like to start with Dr. Ryan. At least in Spain, we have seen significantly fewer cases of VTE associated with the Delta variant. And of course, this might be related with an improvement in the thromboprophylaxis protocols. But I wonder if there is any influence on the standard of care, I mean, dexamethasone and remdesivir and tocilizumab in these findings. Which are your thoughts?
Yeah, I mean, it's a data-free zone. I would say our clinical gestalt also is that the clots are being seen less frequently. I can't quote you chapter verse, but we also have that clinical gestalt. Now, whether that's because the underlying substrate of the affected people, that they don't have so many comorbid conditions of the individuals who were picked off in the earlier waves, and or because we're treating these individuals more earlier in the infection with drugs, I think it's probably going to be very hard to tease apart. But I suspect all of these things are playing into a lower risk, but the risks are still real. I mean, I just yesterday had a 52-year-old guy, no other medical conditions. We intubated him, and he also had a PE, you know, and he had just straightforward COVID, no risk factors other than just being 52 and not being vaccinated, and he had a PE as well. So it is still occurring, but I think it is occurring at a lower burden.
Thank you. Any additional comment from the panel?
Yeah, they're different patients for us. Sorry, Dr. Poo, go ahead.
No, go ahead, please.
Yeah, I mean, we're just seeing a completely different type of patient. So when in the first wave came around, we had 70-year-olds who'd been sat at home doing nothing in lockdown, and then they managed to catch it from either a delivery or whatever contact that they had. And so they were not only higher risk for VTE, they were also completely immobile and much more vulnerable. So the vulnerable patients have all been vaccinated in the UK now. So the patients we're seeing presenting with COVID are a completely different phenotype. So I find it difficult to compare pre and post, but yes, the number of cases I'm being offered to take to the lab has gone down. But I think that's just because it's a different population.
Yeah, I would echo the same thing. It's just younger patients with less comorbidities. The others in general have been vaccinated. So the same risk factors that bring about VTE or elevate VTE risk have been mitigated.
I have one question for Andrew. I wonder which is the role of echocardiography for these patients who are so sick, and we don't know if it is COVID-19 itself, it is pulmonary embolism, they are both. And I think this is important to make decisions regarding interventional therapies.
Yeah, I think that's right. I think just generally their management. I mean, you saw how significant the RV strain was in that patient when they first arrived. And then 6 days later, the right ventricle has apparently gone back to normal on a repeat CT. So what is it that's causing the right ventricular dysfunction or driving it? Is it predominantly the so-called immunothrombosis in the distal vascular bed of the pulmonary tree? Is it some central clot that in this case was mostly unilateral? Is it the bilateral COVID lung that's driving it? Or is it all three? So I think there was a vogue at one point during the pandemic for just putting everyone with severe COVID through the CTPA scanner and looking for clot. I don't think we do that quite as rigorously now, but I think something to assess the right ventricle is important as part of a general management package. Then if you've got pulmonary embolism, I just find it really hard to know what to do with these patients. A lot of them have got right ventricular dysfunction that seems to be completely out of proportion to clot burden and even to the degree of COVID pneumonitis. And so I'm sitting there scratching my head thinking this is a bad ventricle. I'd normally be thinking about reperfusion, and yet what am I reperfusing? So one of the reasons I presented this case today is what to do. You know, all the rules that we've built up over 10 years of catheter interventions for PE with the modern technologies, or maybe 3 years for the more recent thrombectomy tools, none of them apply to these patients with florid COVID lung. So I think all the information you can get is the answer. So yes, echocardiography is part of that.
Very short question. Do you think there is a role for low-dose systemic thrombolysis for these patients?
I'll take that if no one else will. So there was I remember a case series. It came out of, I think, the northeast of the United States, right at the beginning of the pandemic, when there was panic and the whole world didn't know what was coming. And there was a doctor there who said that his ITU patients were having a miraculous recovery if they had low-dose lysis given peripherally. I haven't seen any replication or validation of those data. If anticoagulation is causing worse outcomes in intubated patients, possibly because, as Dr. Poor said, because of microvascular hemorrhage in the lung, you'd have to think that there'd be a very high risk of bleeding-associated complications from lysis. The patients I have seen who've required systemic lysis for large volume pulmonary embolisms while having florid COVID lung have done really badly, much worse than people who are having systemic lysis for PE without COVID lung. So my guess is that there's no role, but it's a guess because I haven't seen a rigorous trial of any kind.
I guess the question is, what is the goal that you're trying to achieve with the lysis? And you have, generally two major issues that are happening with the PE. You have the gas exchange abnormalities, and then you also have the hemodynamic compromise. And in general, our approach to PE in the absence of COVID is mainly for the sake of preventing hemodynamic compromise. But when we have the situation as the case that you just presented, you have, severe gas exchange abnormalities. And the question is, does lysis help that? And if it does help that, who cares? At the end of the day, it's whether the patient survives or not. And, there have been studies that have shown that thrombolysis improves gas exchange temporarily in these patients. But again, if the outcome is not to improve, clinical markers, then it's moot.
We're running out of time. A very quick question for Hooman. Take into account the contradictory results of the multi-platform trials for the WARD patients and the ACTION trial. Which is your clinical practice for these particular patients?
For now, it's just standard prophylaxis, but also altering our suspicion for PE. There's actually, I think, a question that came up in the chat. It says, do existing risk assessment models for VTE risk apply for hospitalized COVID-19 patients? And I think one of the issues is that our suspicion is normally lower because we think, all right, bilateral infiltrates, hypoxemia, we don't need to invoke a PE, no need to search for it. And all these patients have elevated D-dimer. However, as we've seen, these rates of PE are very high. And so we need better kind of ways to assess, VTE risk in these patients. Whether scanning every single person is obviously a little overkill, finding some kind of intermediate way to determine who actually has a VTE, I think is going to be crucial. But for now, without further data, we're just doing standard prophylaxis.
I think there are two comments. I think that we do not need a stratification of the risk for these patients because they have to receive pharmacological thromboprophylaxis unless contraindicated. And for the diagnosis of venous thromboembolism, we cannot rely on the classical clinical probability score, such as the Wells score, the Geneva score. We cannot rely on D-dimer. So if there is a suspicion, you have to go for imaging testing. And I have a final question for Dr. Jaffray. And could you tell us which are the particularities of the diagnosis and treatment of VTE in your pediatric population as compared to the adult population?
So, I mean, not very different, the diagnosis or the treatment. We don't use D-dimer typically outside the COVID to screen for DVT, which is, so it's been a really big change, honestly, to be getting a lot more D-dimers. And I will tell you that the pediatricians, the cardiologists, everyone is learning during COVID. I mean, the hematologists have been using D-dimers, but we're doing a lot of teaching. So that's new, is typically the patients who are getting DVTs in children are already hospitalized. They usually have a central line, their arm or leg becomes swollen. You know, we do not typically have a patient, although last night I just had a patient admitted who was healthy with a PE. But the typical story is you've got a sick kid. In terms of treatment, we are just starting to use DOACs. So it's the phase 3 trials are really just ending. Only a couple of them have been approved FDA in Canada and in Europe. So most of the time we are still using Lovenox. I will tell you as well, using prophylactic Lovenox is not standard. It has also been a huge change, I think, for the better. Being a hematologist, I'm excited everyone's realizing that low dose Lovenox is not going to make our kids bleed everywhere. So for someone whose kind of research life is trying to prevent VTE, I think this is in a way been kind of good, because it has reassured all the other specialists that we can give Lovenox without making these kids sanguinate everywhere.
So thank you. It is 7:03 here in Spain. I think it is time to wrap up. I would like to thank you, the audience, for attending and for participating in this webinar. Of course, thank you to the fantastic panel for their great presentations and for the comments in the debate. And thanks to the PERT Consortium and to the sponsors for supporting this educational activity. You all have a great day. Thank you.